Wonderful. How about we go ahead and get started? Good afternoon, everyone. My name is Hamara Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada. I'm so pleased to have Dr. Anna Lehman here today to talk about Pompe disease in the context of treatments. Dr. Anna Lehman is Medical Director of the Adult Metabolic Diseases Clinic at Vancouver General Hospital and Associate Professor of Medical Genetics at the University of British Columbia. She completed her medical training at the University of British Columbia. Her research program has focused on identifying genetic causes for rare diseases and on improving the diagnostic process for people with genetic disorders. Her clinical practice has a focus on lysosomal storage disorders and mitochondrial diseases. We're so grateful that she accepted our invitation today to talk about the past, the present, and the future of treatments when it comes to Pompe disease. Especially as we wanted to introduce this webinar as part of Pompe Disease Day, which was last Friday. So I can turn it over to you and thank you again. If you have any questions, by the way, throughout the conversation, throughout today's webinar, drop them in the chat or Q&A. We'll monitor them there and then address it at the end of the session. Thank you.
Thank you very much for the invitation to speak to everyone today. I will say that I have more involvement with adult patients since I work in an adults-only clinic. I do have a bit of experience with kids who have Pompe disease as well, but forgive a bit of an emphasis on adults today. So our objectives, just to review what Pompe disease is, review how it's currently treated and managed with a multifactorial approach, and then we're going to look at new treatments that are coming down the pipeline, some others that are in development, and look at some other aspects of overall management and understanding the disease better. So let's dive right in. Okay, so what is Pompe disease? It is a muscle weakening disorder that has a few other multi-system effects, but the main features are weakening of certain muscle groups disproportionately relative to other muscle groups for reasons that we haven't entirely figured out. We find there's a weakness of the muscles that control the trunk, the hips and the shoulders as being the most effective. The respiratory muscles, so again, those are muscles that are in the trunk, including the diaphragm and the muscles in between the ribs that are responsible for inhaling and forcefully exhaling. And in infants who have a severe form of the condition, which the condition's on a spectrum, will also have involvement of the heart muscle and will have weakening of that muscle. There can be additional features. Rarely, adults can have involvement of their heart. Scoliosis could develop as a secondary consequence. Scoliosis is curvature of the spine and can happen when the muscles that are supposed to support the spine are weak, and there can be a bit of collapse of the spine. Aneurysms, that's these dilatations, little ballooning out where there's weakening of the wall of blood vessels, that seems to be fairly infrequent in terms of causing problems like rupture, but it is something that all patients with Pompe disease should be screened for. Weakening of some other muscles involved in swallowing, speech, eye movements, that can occur, often a more subtle finding, fortunately, and not a major focus of disability. Hearing loss, again, often just a bit more than the background population rate. Of course, as we get older, we often have hearing impairment. So again, this doesn't really set apart Pompe patients so much as the profound weakness of the hip girdle and shoulder girdle. And sleep apnea. So most of the respiratory problems are because, the lungs aren't opening up enough, but part of the problem can be that there's collapse in the upper airway, which means it's hard for the air to get through in the first place. So there can be other factors that can make that worse as well if a person is heavier, and of course that can be easy to gain weight if a person is not able to move around as much as easily and get as much exercise. So that's the condition, again, mainly what we call a proximal or sort of near the middle of the body type muscle weakness with breathing impacted. I made a cartoon to try to show you what's happening in this disease, why there's a problem. Glycogen is how we store carbohydrates. So we're not eating constantly, but our body needs a constant source of glucose. Our cells then will package up extra carbohydrate in the form of glycogen, and then will pick it apart to burn as needed. Most of this glycogen is stored just sort of floating around in the cell. This is a cell that I'm showing you here. Periodically, as just sort of a natural part of cellular behaviors, everything that's just floating around will get broken down a bit and taken and recycled. Maybe this is because there was like a little bit of excess glycogen, more than the cell needed, or it was kind of getting ratty and old. It's going to go get recycled in a compartment called the lysosome, which is the recycling center. So there's a little bubble taking some glycogen into the lysosome to get recycled. Inside the lysosome, it's a very acidic environment. Acid is very good at breaking down bonds, chemical bonds, so good for recycling. So its own special environment inside there. And there are enzymes inside there to do the recycling work. An enzyme it's a protein, like that's its chemical form. And enzymes are proteins that have jobs to do. They chemically transform one thing into another. The enzyme that's deficient in Pompe disease is called acid glucosidase. So we have different kinds of glucosidases. A glucosidase is something that breaks down glycogen. There's just like regular glucosidase that's just floating around in the cell, but then there's a special form called acid glucosidase that's able to function in the acidic environment of the lysosome. And that is the one that is deficient in Pompe disease. So there's a buildup of glycogen inside the lysosome. So there's no deficiency of energy or carbohydrate or glucose. That's not, there's plenty getting broken down just from those extra stores that are not in the lysosome. They're getting used fine. But what the problem is when there's a buildup in the lysosome, then it shuts down the entire recycling system. So the recycling center is kaput. And then this whole cell suffers. And again, we don't have all the details worked out as to why this problem is so significant in certain cell types more than others, because yeah, all of our cells have glycogen and lysosomes, but there's something about these cells that really suffer the consequences from this. So more mysteries to uncover, but that's the problem. It's a breakdown of recycling. There's a fancy scientific word for that called autophagy, self-eating. And so that's maybe a future avenue for research and into other treatments and helping to restore a normal recycling system. So as I mentioned, there's just a continuous spectrum of severity that Pompe disease can cause, and largely that relates to how whatever genetic changes have happened to that gene that make acid glucosidase, how damaging those changes are. Some of them may only slightly alter the enzyme. Others may completely wipe it out to the point that there's actually no enzyme even made, dysfunctional or not. And so that's going to largely determine whether a person is going to have the infantile onset, which includes the cardiac, the heart involvement, versus a later onset. And there's two groups that are used just arbitrarily, in our medical specialty when we're talking about Pompe disease. And one is infantile onset, which means two things. There's onset of the weakness started before the first year, before 12 months, and there was weakening of the heart, versus late onset, which is everybody else, like from age 13 months on. So we do see, however, people who do not have problems with muscle weakness, do not present themselves to medical attention until their 60s, or there's even a case reported at age 70. There probably are other, genetic background factors that can help compensate. Certainly there are lifestyle things like exercise that can help compensate as well. So how is a diagnosis made? In Canada, we have our own practice guidelines that specialists follow. So we're talking about neuromuscular neurologists being the ones who usually make the diagnosis. In the past, medical geneticists like myself might have been more involved in the diagnosis, but we do have better and better access to genetic testing that our neurologists are able to fairly easily order themselves. So nowadays, it's usually made with genetic testing, and then to confirm it and to be sure about it, the acid glucosidase level can be directly measured in blood, like how active is it, how well is it working or not working, and you put those two pieces of evidence together, and if they add up to a diagnosis, then that's enough. Occasionally they can be a bit equivocal, so the genetic variants observed might be really rare and not seen either in healthy populations or in patients with Pompe disease before. And then if you got a level of activity of the enzyme that was borderline, it was just a little bit low, so that happened, there's a overlap gray zone there, then you may have to, a physician may have to kind of use their diagnostic abilities to look at all the evidence to make a decision about a diagnosis. And other things then that can add up to a diagnosis. I mentioned that one mystery of Pompe disease is why some tissues are so much more affected, and within the muscle tissues, why some muscles are more affected than others. So here we see this is an MRI of a leg, so it's kind of a cross section through it. You just see there's fat tissue around the circumference, and this is the back of the leg, the hamstrings, and the white means that's not healthy muscle. There's unfortunately been some death of the muscle cells with some scarring in there, and then a bit of fat just sort of settles in as an after effect. But yet the quads and the front part of the leg on top look quite good. But so you see that pattern, and it does suggest, okay, this does look like Pompe disease. The needle tests that are done sometimes to look at how much activity a muscle has, like how strong a muscle is, by stimulating it electrically, you will see that in a patient with Pompe, usually the worst affected would be the muscles along the spine, and again, that's kind of characteristic for Pompe disease. It's not perfectly specific to that, but you just sort of add everything together to get to a diagnosis. Years ago, we were very reliant on muscle biopsies, where under a microscope you could visualize all of that buildup of the glycogen inside the cells, and you would do these stains to see what it was, just to confirm it was glycogen. So I don't think we're going to do that very much in the future, because the genetic testing is getting better and better. And then there's the biomarkers. So you can measure circulating around in the blood the buildup of the some of the glycogen that leaks out from the damaged muscle cells. It'll float around, and it's a characteristic form when there's a problem with glycogen breakdown. So we call that hexokinase 4, and CK is just a bystander protein that you can measure whenever there's breakdown of muscle from any cause. So it's a standard test for just diagnosing a muscle disease. I created fake cases that are nonetheless typical for ones that I have seen, and just give you a sense of what this disease looks like for people who have differing degrees of severity. So we'll talk about Ethan. He was born at term, seemed healthy at first, as a newborn. He did have a bit of a hoarse cry and lower tone. Tone is just, you know, when babies are born, they're kind of just all tight and scrunched up. And a baby who has low tone just will be a little bit looser with how they're holding their limbs when they're resting. At one of his first checkups with his pediatrician, it was noticed that his liver was big. So just, you know, checking the tummy, the firm liver could be felt much lower in the abdomen than it should be. So that led to tests to figure out why that was. And it seemed one part of the cause was that his heart was enlarged and it was weak. And that can cause the liver to be big. Plus the liver can be a bit bigger just from infantile Pompe on its own. So he was not well. He was admitted to hospital, and quickly a bunch of tests were figured out. There are lots of reasons why a baby could have a weak heart, but the fastest test that was done was measuring the enzyme level, and that was shown to be low, very like absent, negative, nothing. That confirmed the diagnosis on its own of Pompe disease. There wasn't any gray area there. So that, let's say that whole process in our Canadian healthcare system, I think that might take, you know, about three months. So you might have a 3-month-old getting the diagnosis at this time, because we don't have, there's no newborn screening in Canada at this point for Pompe disease. Childhood onset, talk about Jamie. He was a bit later than his siblings to walk, run, and jump, but he was full of energy and enthusiasm. So, you know, no one was concerned. In grade school, he was not able to do the monkey bars on the playground. He couldn't keep up very easily in gym class. Again, no one was too worried about that, but there was an event one day at the lake when everyone went swimming, and he was having trouble breathing, and he actually panicked a bit, and his mom jumped in to pull him to safety. So this rattled everyone. So they did end up getting a series of appointments with doctors and eventually to a respirologist as to why it had trouble breathing in the water. And he was found to have low lung capacity. And the reason for the low lung capacity was found to have a weak diaphragm, that muscle, key muscle for breathing. So he then saw a neurologist who did a muscle biopsy, and that showed the buildup of glycogen, characteristic of Pompe disease. So then it was really just confirmatory follow-up genetic testing and enzyme testing to make the diagnosis. I mean, that whole process, unfortunately, could take like 2 years. Like if he was otherwise well, apart from that one incident, you know, things can be slow. Like if this is the course that things took, we hope we're going to find ways to make this faster now and going forward in the future. But to get a muscle biopsy in our hospital, I used to work at the Children's Hospital, you know, for a kid to have the general anesthesia, we don't do general in our adults, but that's generally what was done with kids. I mean, it could be like a year to get that OR spot. So definitely a better way forward is just getting genetic testing done as soon as possible. And then an adult onset case. Let's talk about Mariah. She had just never been able to do a sit-up, also had trouble keeping up with her peers in sports, but, you know, fully normally functioning. It wasn't until her late 30s when she was noticing progressive decline in her abilities. Hiking and cycling became too challenging to do. So she mentioned this to her doctor, but it kind of got interpreted as fatigue at that point. So the doctor was just checking iron and thyroid, and those were fine. But by age 42, even stairs were hard, and she was walking differently. Her partner commented on that. So she knew something was wrong. And she did get referred to a neurologist. They did a CK test, very routine, whenever there's a muscle complaint, and that was quite elevated. So then the neurologist referred to a subspecialist neurologist in neuromuscular, who did some EMG testing and also found that those back muscles were identifiably weak with the EMG testing. And that neurologist was able to just go straight to genetic testing, skipping the muscle biopsy, and the genetic test results were in keeping with Pompe disease. And the enzyme test was done just to fully confirm it, and the diagnosis was made. So that journey could take about 4 years, let's say. Why does the diagnosis take so long? Well, just in general, the slower and milder a disease, then the longer it's going to take for the diagnosis, because the urgency may not be there. Some of those early symptoms are muscle soreness and fatigue. So that can sound like much more common disorders like fibromyalgia or chronic fatigue syndrome. They're much more common. Before we had better access to genetic testing, it was, again, required just these many other ancillary tests. It's only been very recently that there's been better access to testing. And a lot of people are diagnosed with limb-girdle muscular dystrophy. Not surprising, because it is a limb-girdle, and those areas, and it's thought maybe 3% of people who have a diagnosis of limb-girdle actually have Pompe disease specifically. And then in adults, there's always this disadvantage if you have a genetic condition that's presenting in adulthood, because acquired conditions like auto-inflammatory, autoimmune stuff is more common and more likely. This graph is trying to show you on this logarithmic scale of how much cheaper genetic testing has gotten. And that's the key reason that we now have it available as a ready access tool. There was a new technology that was invented around 2009 that made it possible to check for many genetic diagnoses in one single test at the same time for a reasonable price. And then that's just been working its way, into our healthcare system in common practice. But it was technology that has made this happen. Newborn screening has been expanding in the States and in other countries. There's lots of papers coming out with each state sharing what their experience with that has been. And this is just one of those studies recently that's just fairly typical. So let's say there were 435,000 babies born, 16 of those were diagnosed as positive for Pompe, the vast majority being predicted to be late onset, and 2 with the more severe infantile forms. But out of those 16, 6 of them, there's not confidence that the person will for sure get Pompe disease. So that's probably the main downside of newborn screening, is potentially having individuals living under the umbrella of that diagnosis, but also, hoping that maybe there can be clarity with advanced testing as the years goes on, but for the time being, having some uncertainty as to actually whether or not they have the condition, but yet having to go through monitoring and assessments. Pompe disease is rare. Different studies come up with different frequencies of the condition, anywhere from 1 in 14,000 to 1 in 400,000. There is one particular variant that's more common in the African American population. But apart from that, about 1 in 100 people are carriers for the condition. Of course, if people are marrying in their family, as is a common cultural custom in many parts of the world, then there would be a higher chance to have Pompe disease because it's recessive. So both parents have to be carriers, and then they give down their gene combinations. And if there's 2 carriers, there's going to be a 25% chance for each child to be affected. The gene is called GAA, which is just an abbreviation for the acid alpha glucosidase, that enzyme. One little tricky part about the genetic testing is that it'll say if there's 2 variants, like 2 variants to the change, but it's not able to tell you if it happens to be that both those variants came from the same parent, versus what you want to see for a diagnosis is that one came from one parent and one came from the other. So sometimes we have to get DNA samples from parents just to be sure. And these variants of uncertain significance, those equivocal results, that does continue to be a bit of an issue, but less and less over time. There's one specific change in the gene that we tend to see in people who have the late onset form, and it's a milder variant. So then that makes it the milder later onset type of disease. So our genes are actually in our cells, they're cut up into pieces, and our cells have to piece together the pieces before it can then use the gene to make the protein, to make the alpha acid glucosidase. It's got to piece together the pieces, and any changes in the code can sometimes disrupt how the pieces are put together. But this particular variant, when that variant is present, it's like sometimes the cell puts together the pieces the right way, and then sometimes it leaves one of the pieces out. And then that makes it milder, because some of the acid glucosidase, it works fine, and then some of it doesn't. This is just showing you a picture of your genetic code. It's a series of 4 different chemicals. So it's essentially a 4-letter alphabet that's makes this very long series of books, if you think about it like that, that contain recipes for how to build all the proteins of our body. And there can be any number of things that change the code to be something different. All right, treatment. So Pompe, we approach it from different aspects. And I think the most important is that the person has a very regular routine of exercise that includes strength or resistance training and stamina training. So cardio and strength, both, in order to maintain their functioning. So this is obviously important for everyone, but it's critically important for people with myopathies in order to stay above the disability threshold, because they're so close to the disability threshold that then throwing down, deconditioning on top of that can be the difference between independence versus disability. High protein diet, we finally recently got, we always suspected that this was very important, but we recently got hard evidence that it does help. Specifically in Pompe disease, I'll talk more about how it helps. The other one is enzyme replacement. I'll get into that. And then respiratory support. So if someone's not breathing adequately, they'll have a whole host of downstream problems, including the risk for death if their oxygen level dips too low, especially when they're lying flat, and then it's harder to breathe when you're flat. So this is very critical that this is identified and screened for, and then treated with some assisted breathing as needed. Okay, so the exercise training, we usually refer to physio or physiatry, which is a doctor form of a physiotherapy. I mean, they do more than that. They do rehab and can make an individualized program for a patient based on where they're at. And this should include, again, some cardio. It seems like the best thing is either walking or a stationary bike. Some of our patients have purchased the stationary bike that sits on the ground. So they're cheaper. So you're sitting on a chair and then you're pedaling. It's a pedal sizer. There are different brands, and you can do it while you watch TV. And then, depending on what the level of weakness is, different exercises for strength may be appropriate. And there was one study, there's been different studies finding different degrees of improvements based on exercise, but one of them found a bigger improvement than from the treatment of enzyme replacement. So this really is critically important. Respiratory muscle training helps. So there are the various devices, where one tries to just basically breathe hard, and this can be measured, and titrated to a specific goal. We need a special, respiratory therapist to do the instructions for patients. But if they're willing to do this a couple times a day, there can be benefits from this. And the high protein diet. So our cells, most of our cells primarily use carbs for the most part, but of course we can also use fats to get energy, and then we can also burn proteins. We don't just use proteins to build our bodies. The proteins can be broken down into amino acids, and those can be actually changed into carbs. The amino acids can be changed, and then you bypass the breakdown of the glycogen. And then if you're just kind of not breaking down the glycogen so much that's floating around in the cell, then you have less going into the lysosome. So we definitely have this theory that that's one reason why it might help, is just stop going to the glycogen to begin with, and just having this sort of straight protein transitioning into carb pathway. And if that's what your diet is, that's what will happen. The other aspect is that our bodies do have a healing process. And so when there's damage to muscle cells, the body's always trying to heal and recover those muscle cells, but that requires a lot of protein to do successfully. And so then we're maximizing that by having lots of amino acids around to rebuild constantly. So one recommended diet, it's easier, just people can track their macros with apps, but I think we just generally say try to get as much as 2 grams per kilogram per day, which is a lot. That's really hard. So I think everybody in the world needs a protein shake to be able to reach that. And so we make specific prescriptions on protein shakes. Okay, so the enzyme replacement, it's an enzyme that's missing, and fortunately you can kind of synthesize or mass produce that enzyme in cell cultures and then give it IV. So that treatment has been around since 2006 for Pompe disease. And it has been absolutely life-saving for many infants with the early onset form. It's remarkable how much it improves the cardiomyopathy, the weakening of the heart, quite quickly. It is not a cure by any means. Especially infants who have severe disease to begin with will continue to have quite a bit of muscle weakness. And in adults, they have been quite weak when getting diagnosed at that point. And our main goal is to stabilize and hold steady at whatever point, they were at when they were diagnosed. And enzyme therapy helps a lot compared to what it would be like if they weren't having enzyme, which would be a progressive weakening. So in this trial, which is how we determine, well, does it work? How much does it work? Is giving a placebo, giving nothing versus, and they did a real placebo with an IV because this has to be given by IV. And basically over 78 weeks, so a bit over a year, this distance walked in 6 minutes improved from 332 to 357. So not even just like holding steady, but there was an improvement versus we are seeing that a little bit, tiny bit of decline from 317 down to 313 in the placebo group. And that was statistically significant, saying that it's better to be treated with this than not treated. And that was the basis then to get treated. When looking at the lung function with the respiratory muscle strength, that saw an improvement in the treated group, and in the not treated group, it got worse over that 78 weeks. So, and that was very statistically significant. Challenges with that treatment, there are quite a few. One is that it's very expensive, and that's not entirely because it's an orphan drug and the company's trying to make a profit when there's not very many customers, but it's just expensive to make. It's quite complicated to produce an enzyme. It's a very complicated molecule. It's it's this kind of living organic source that you need to make it with this fancy machine called a bioreactor. Oops, sorry. And it has to be given IV, which makes it kind of complicated to set up for patients. If you ate it, it's a protein, you would digest it. And unfortunately, only a small bit of it gets where we're really wanting it to go, which is into the muscle. To get inside a cell, there's these little receptors, little lock and key doors, and the muscle cells just don't have many doors on them. So that's just an intrinsic issue. There can be allergic reactions. About 5% of people can have a fairly serious allergic reaction that we can usually manage with medications. For infants, a very big problem is their immune system might destroy the enzyme, because if they're not making it at all in the first place, their bodies will think it's foreign and potentially from an infection, and will try to destroy it. So infants in that situation are usually have their immune system suppressed as they're getting started on the treatment. It's obviously an impact on lifestyle to be tied to getting an infusion every 2 weeks, and it takes pretty much the whole day to get the infusion done. And then it's once every 2 weeks, but it's only once every 2 weeks. So there's most of the time there's not a treatment happening. It takes a long time to come up with new.
Quickly just review here what it takes for a novel compound or novel biologic to become a medication and treatment. First,
oh my gosh, that's me. Oh my gosh. Okay, I'm gonna I was like, who's talking? Sorry, I had given this is a slide from a recorded talk. My sincere apologies. Yeah, I've given talks before about treatments for rare diseases and why they take so long to get through. So just so that you know, first someone has the idea, then they do tests in cell models, so like in cells to see if they're getting rid of glycogen or increasing enzyme activity. If it looks good there, then you move on to animal models and see if it improves the animal's disease. And then you can move on to humans. And the first step in phase 1 is just to make sure that it's safe. So usually there's dose escalation where you just give a little bit and no harm, then you give a little bit more. And these are usually healthy adults who are willing to be altruistic and be tested with novel medications. Phase 2, you're going to do in patients, and you're going to figure out what is the right dose exactly, and how is it given, what's the best frequency, and confirming safety further. And key thing, checking to see if there's any evidence that it's helping. If that's positive, if it looks like it is helping, then there's a proper phase 3 clinical trial, which is designed to prove that the treatment does work, and how much does the treatment work? How much does it help? And that whole process just takes decades to go through. Sometimes in rare diseases, you will combine phase 1 and 2. So you'll just start out with people who have the disease. Sometimes you don't use placebo if you're expecting a really dramatic, like obvious effect, then regulatory bodies would accept historical, which just means like patients who've been studied, and just say, well, this is how they do, this is how they deteriorate, and then look at these patients who are all treated in the study. But you need to be expecting a pretty dramatic change to do that. Okay. So the new thing that just got approved by Health Canada late last year is a newer version of enzyme replacement that is proven to be non-inferior. So equivalent. It's definitely equivalent to the first generation of enzyme replacement. But when you look at all the evidence, so I'm speaking my opinion here, it appears to me that it is probably, even though it wasn't proven, it is probably a little bit better than the first generation. The new idea with the next generation is, I said that there's a lock and key mechanism to get into the muscle cell. So they loaded it up with more keys. It's just like completely studded with keys, so that any door is any lock on the muscle cell is going to make contact with a key. If there's a door, it'll get used. So it's a great concept. And what happened basically in this trial, this clinical trial where they were doing what's called a head-to-head, and they split people up evenly to either get the new generation called avoglucosidase or the first generation called L-glucosidase. So it's a head-to-head, which one's better. They had to pick, I guess the company was told they had to pick one outcome that would be the determiner in terms of better or not better. And I think because of that previous trial I showed you where there's a really big difference in the in the lung function, that they went with the lung for this one. Presumably that's why. It was very close. So the improvement was 2.89% better versus just 0.5% better with the old stuff. And this was very close to being statistically significant, to being proof, but it wasn't quite over the line. And then the secondary endpoint, well, number one would be that 6-minute walk test. And it was statistically significant. It was better. You got a 32-meter gain, better performance with the new generation versus a 2-meter, which is interesting because that's worse than in the first study. So sort of unclear why. But anyway, that was statistically significant, the 6-minute walk test. But there are very important reasons why these rules are so strict about how we draw conclusions if things work or not. Obviously, scientists, companies have tremendous pressures on them to have their thing work. They've invested so much, so the rules have to be really strict, and you set them up front as to what's going to be the decider. There are some other improvements here. This one, the quick motor function test, is statistically significantly better. I forgot to do my disclosures. I'm very sorry, that's unprofessional. I have received consulting fees from the maker of both of these enzymes, Sanofi, and I'm trying to do my best to mitigate that conflict of interest by just using the generic names as one strategy. So there's these are the only products right now in Canada. So, and there's not much else I can do to mitigate it. Okay, let's carry on. Okay, so I mentioned that one issue with ERT is that you're getting this big spike in your blood, circulating blood here in this diagram. And then we think that it does last longer in the muscle once it gets in there, that the protein survives for a while before it's broken down and goes away. But you definitely have these time periods where there's no treatment happening. That's not ideal. With kids who are more severely affected, people have been playing around with the doses to see, they're so small babies that it's not that expensive to just give them double dose or give it twice as often, unlike an adult, which would be not really possible because of the cost, because it's the cost is based on how much you use, which is based on how big you are. So this study, looking back, just retrospectively looking back at, okay, this clinic was treating their kids with twice the dose, twice as frequently. They were using twice the dose at the regular every 2 weeks, or they were using the normal dose every week, or they're just doing what's the standard, which is just the regular dose every 2 weeks. And so they looked back recently to see what the difference in the outcomes, and it appears that kids who got the highest dose, highest frequency had longer survival. And so we may be seeing more consistency over time in giving the kids with infantile onset that higher dose at twice the frequency, which again is economically feasible for a healthcare system potentially. So, maybe there'll have to be more studies. We'll see how that plays out. So how could we give a higher dose all the time? Well, with gene therapy would be a good strategy to do that. So you could deliver a working copy into the body. To deliver it, one way is to use a synthetic version of a virus. And those are really good at getting into liver. They can get into other tissues as well. Muscle, not quite as much as liver, but let's say you really saturate the liver, it's going to produce and release a lot of this enzyme that it's making. It will circulate and get taken up, and it'll be circulating 24/7. So this seems like a really good concept to me. There's two competing forms of gene therapy right now. The dominant one is using a virus called AAV, adeno-associated virus, and the other is called lentivirus. The lentivirus on the right in this picture, you actually take out blood stem cells from a person, you treat them with the virus in a petri dish, and then you get rid of the virus. So no virus goes into the body, and you just put those cells back into the person after they've been treated. These are blood cells, and you have to give some chemotherapy to make room for these cells to then have a home and divide. So it does have to be done in hospital. There's been concerns, well, actual events a couple decades ago with kids having lentivirus gene therapy and getting some blood cancers because they were giving kind of a very active form of the gene because they wanted to make lots of the enzyme. This wasn't for Pompe, this was for another disease, and they did get cancer. Now there's been quite a bit of modification to dramatically reduce the likelihood of that happening. AAV, I think there's about 3 of these trials enrolling right now for Pompe. And it's seems to be, we do not have confirmed causative cases of cancers happening right now. And there has been quite a number of years of experience with humans, especially in like hemophilia and thalassemia blood disorders. So we're not really going into a blind at this point. But there's still very long-term questions. You know, it hasn't been decades, so it's still experimental. But the goal is to measure good levels of circulating enzyme. Main downside of this one is that unfortunately the synthetic AAV is quite similar to just the natural AAV that many of us have had, and if we already have an immune response, it has no chance of getting into our cells at a decent level. Even for people who are not already immune to it, they do have to have some immunosuppression for a few months on average, because the body will recognize that, hey, like there's kind of like a virus in these cells. I'm going to just destroy these cells to clear it all up. So you have to shut that down so that once all the markers of the infection are gone, then you're in the clear, ideally. Okay, so why do we need better therapies? Because, well, we do have really good stabilization with ERT. That is the good news. We are seeing in our clinic good stabilization. And here's some data for 5 years with lung function called the forced vital capacity. And this black line. So all the colored lines are just all the patients who are in the study. You know, so FVC is going up and down. You know, if they have a cold or bronchitis, obviously it's going to go down and come back up. And there's this sort of normal variability too. But there's a slight decline, but pretty stable over 5 years. And this other study, they were looking at their patients over a longer term. And it does also look pretty good with that. Let's look at that red line over, I'm sorry, you can't see, but sort of over 5 years here. It also looks pretty stable. But then if you go out to 13 years, there's been a drop if you start from here and you go down to here of about 15%. So as you extend out, there will be declines. The green line is the 6-minute walk test, and you know they don't have huge numbers of patients here, but that again you can see there's been a decline in the green line. The blue line is that motor scale, and there's been a decline there as well. Okay, so I'm about done here. What lies over the horizon? Here's just pure conjecture on my part. So take it or leave it, but I am confident we're going to get better and faster with diagnosing patients earlier, thanks largely just to an ongoing improvement in access to genetic testing. But we still definitely have work to do, and we have some primary issues to work out. In terms of like which doctors, you know, could be doing this testing, et cetera. Earlier treatment, obviously that, you know, for stabilizing them, we want to stabilize at a good, nice high level function. And I expect the way things are looking so far with these reports coming out from states doing newborn screening this is purely my prediction, but I do predict, I think there's going to be an expansion over time of newborn screening but it may be a while. I mean, we need more evidence for sure, and understanding how that plays out, and making sure that we're maximizing benefit to and minimizing harms at a societal level. I think we will see approval of gene therapy. That's my prediction. We may see some what are called biosimilars, which are generics, and maybe that will help with reducing the costs of treatment. Maybe not. These are expensive things to make to begin with. So we'll just have to wait and see how that plays out. All right, so that's the end of my talk. I'm happy to take any questions.
Thank you so much, Dr. Lehman. Thank you for a really clear discussion, and really appreciate some of these predictions and what can lie ahead. I wanted to go ahead and look at the chat, and I also see some questions in the Q&A. Interestingly, there's 2 questions in the chat that are related to combination therapy. So the first question is, do you foresee, or is there an available data around using the 2 enzyme replacement therapies together, and will that make it more superior?
I don't think so, because when you're giving the dose, the dose is very high. So there's probably not, there's probably a ceiling effect. I mean, yeah, maybe, based on that infant paper, maybe we should be going higher with the dose, but I don't see those two different products being fundamentally different. So if we were going to go with a higher dose, then, I would use whichever one I had available to me, or whichever one the patient we had decided on to use that we had access to. So I did not go into some other products that are under investigation and development that work in different ancillary ways. So like some products that may separately augment the entry of the enzyme into cells. I didn't get into it because let's just focus on the things that, have real evidence. So maybe there will be some stacking if we have a sort of a separate drug that really gets the drug into it. But at the moment, I don't see stacking as something we're thinking about right now.
Perfect. The other question, interestingly enough, that was on combination was about whether enzyme replacement therapy, whether the version that was just approved now, and Myozyme, coupled with a high protein diet, result in better outcomes, or coupled with rehabilitation, or a combination of the 3. Can you speak to that?
Yeah, so the study, there have been studies looking at that. So yeah, the ideal, you get more benefit the more you stack those things. Absolutely. So yes, very good to exercise, better to exercise and have enzyme, even better exercise, have enzyme, and a protein diet. There is evidence that you keep getting more benefit when you stack those things together. Absolutely.
Perfect. This question here is, do you feel there's a risk to the liver to use it to deliver the enzyme when that's not a normal task for it? And I'm just wondering, go for it.
The liver is an amazing organ that makes all kinds of proteins for our body. It makes all of our clotting factors, for example. So I don't think it's going to be stressed at all by making one more thing. I've never heard of that concept being observed in the pretty vast, we have thousands of gene therapy trials that have been done at this point. So that's a very interesting question, but the liver, I think this is a drop in the bucket for it to add on making more enzyme for the body.
Very good. There's another question here around the lock and key analogy. Why is it used? And then also with regards to the Nexvia study, it sounds like it's very similar to the original study. Can you speak to that?
Yeah, so first question, like the lock and key called the mannose-6-phosphate receptor. Yeah, that's a really good point that I'm not sure that I've seen the real evidence, but I haven't thoroughly looked into the animal models and the cellular models that is what's happening, that is what's driving the potentially mildly superior effect. So we do have to be careful to draw that from conclusion that that's how it's doing it. That's what it was designed to try to do, but I can't confirm that for sure that's how it's having its effect. So I appreciate that comment. And then the next question about I think this is getting at sort of well, this Lumizyme or the original, the algoglucosidase, it's been tested twice in what we call treatment naive cohorts, right? People who are starting out on treatment, and then you're looking to see how much better you're getting after getting treated. And there were pretty different degrees of improvement in that first original trial versus how much the gain was in this more recent trial in the head-to-head. And I've looked quickly. I thought, oh, it's got to be the age, because we know Pompe gets way worse with age and it's harder to treat in people who are older. I thought maybe that's it, but they looked pretty similar in the age. So there's got to be an explanation, but I haven't come up with why that is. But what you said, I think the comment's gone, but there's a lot of just noise. And that's why clinical trials are so important. You can't, I mean, you try to with meta-analyses, but it's hard to, it's hard to, there's always different, these are small, relatively small studies, and there's different things going on with those patients or different patients. So you do have to have a clinical trial that's properly designed to answer the question, and then trust the answer if the statistics are authentic and genuine.
I think that was actually great that you were able to present even the differences between the different clinical trials, and even how the phase 1 and 2 are sometimes collapsed for rare diseases. It's helpful to understand the process. And then also it was really helpful to talk about what can be a delay in diagnosis or delay in access to treatment, which brings me to the question that is in the chat around, has COVID changed your management of your patients? Are you happy supplementing your management with virtual engagements?
Yeah, it's we have a big province in British Columbia, and we just have this one tertiary care center in Vancouver, and our model was always the patients have to travel all the way to us so that we can do all their assessments and whatnot. But I think we've grown, and we've learned. First of all, we got access to telehealth that we didn't have before, and so for patients where we can get their assessments done locally, we're presenting that as an option. So this is a big win for people who don't want to have to travel and bear that expense and hassle and so forth. So that's the main thing. But it's been, I think it's mainly just been for the better. And
we've heard that with our interactions with clients, even around home infusions, and how much that's also improved over time as well. The last question I guess I'll leave you on is they're really appreciated that you talked about newborn screening. MDC is working on a cross-Canada initiative around newborn screening for spinal muscular atrophy, where there are disease-modifying therapies available. And of course, we're thinking about, as an organization that represents a broad set of neuromuscular disorders, including Pompe, but to your point, really balancing the evidence with the ethics. And this brings me to the last question that someone had in the audience, which was around the comments you made. I think it was based on the US data, where for 6 individuals we weren't confident that Pompe disease would present. Can you speak to that a little bit more?
Right. Now, I don't remember exactly what their genotypes, like what their genetic variants were, but that one variant that I talked about that changes, how the gene is pieced together, spliced together. I think there's still a bit of question. What happens when somebody has 2 copies of that very mild variant? So I don't know if that was the situation. Hopefully we get to the bottom of that, like within the next couple of years, of what really is the significance of that, because I see that combination coming up in talks. And my understanding is I thought it was very unlikely that people would get Pompe if they had both of those, but I think there's still an evidence gap there, so that maybe that can get answered. So that's the main issue, is like the variants that they're coming up on the genetic testing, is that we just don't have enough information about them to accurately predict. So solvable, but it'll take time.
And then maybe we'll just end right on this question. It was connected to what you just mentioned. Are there biomarkers or predictors of who could benefit more from these different enzyme replacement therapies or gene therapies? And is that the way we're going?
Well, I will reference, the guru, Dr. Kishnani and Duke. She's just been coming out with great stuff that they've been working on with these kids, babies who've been getting these positive late onset newborn screens, and some very subtle kinds of assessments that they do looking for muscle involvement. And I think the approach is right to try to, once you're convinced that there's muscle degeneration with some of these assessments, then to start treating earlier rather than later. The Canadian guidelines, is basically if someone's showing signs of muscle weakness, start treating. I think you're right. There will be ongoing questions about if we do get really subtle biomarkers, then when do we treat? That's still going to be a question.
With that said, let's go ahead and end today's webinar. Thank you so much, Dr. Lehman, for a really clear presentation, for taking the time to answer questions. It's been a really robust and interactive Q&A, but also the chat session. If there are any additional questions, of course, I'd like to remind everyone in the audience to email research@muscle.ca. We'd be happy to provide that information to you or connect to experts like Dr. Lehman and get the answers for you. And again, thank you so much for joining us today. Have a good rest of your afternoon. Take care, everyone. Thank you, Dr. Lehman.